talking about the history of the plant, I won't go into a lot of detail, but the plant's been dated back to at least 3000 BC in literature in China, and some scholars believe cannabis was actually originated at the beginning of humanity, essentially back in Sumerian times, well before Jesus. So it's definitely an amazing plant, and it's definitely a very good medicine, as proven by our coevolution with it over time. Now everyone knows about THC, the main cannabinoid in cannabis, and the second main cannabinoid is CBD. So these are the active ingredients, the two main active ingredients that come from the cannabis plant. And these ingredients are the main two that we consider when dealing with our patients. So THC has many effects as well as CBD, so including analgesia, antispasmodic, or muscle relaxant, appetite stimulants, anticonvulsant, antiemetic, assists with sleep, it's an antidepressant, it's potential in apoptosis for killing of cancer cells, it's an antioxidant, neuroprotective, it's anti-inflammatory, and it's anti-hemangiogenic, and it's a bronchodilator. So that's THC, tetrahydrocannabinol. In addition, THC is the psychoactive component of medicinal cannabis, or cannabis generally. So this is, I consider it the more potent cannabinoid, and it's the one which we should consider carefully when dealing with our patients. CBD, on the other hand, has no psychoactivity. It is analgesic as well, and importantly, it dampens the psychoactive effect of THC. So it's a THC antagonist. It can be used clinically in this sense. It's an anticonvulsant, an antioxidant, an antipsychotic, an antidepressant, anti-inflammatory, a neuroprotective and neuroregenerative substance. It's anti-metastatic, it's osteogenic, and it's anxiolytic. And you'll notice throughout my talk there's lots of pictures of the cannabis plant. And this is important because this is where we get our medicine from. From these crystals on the plant that are called trichomes. These are the parts of the plant that contain the most cannabinoids and is what we extract into our oils. So I won't go into a lot of detail. There's a lot of detail we can look at here, but there is also a lot of studies that have been done on these compounds already. I won't go into each one of these studies, but THC has been shown to be analgesic, antiemetic. It's one of the main reasons it's used in cancer and nausea and vomiting patients. It's anti-inflammatory, it's a bronchodilator, it's a muscle relaxant, which is important for multiple sclerosis patients. It's an antioxidant and it's neuroprotective, and it helps against diseases of neurodegeneration such as Alzheimer's. So this is THC. THC effectively mimics our body's own endocannabinoids. I'll get to that in a second, and that's how it works. It binds to the same receptors which our body's cannabinoids bind to in the endocannabinoid system, and we're going to get to that very soon. CBD. CBD is the other major component of medicinal cannabis. There are 144 or more discovered cannabinoids at the moment, and many more flavonoids and terpenes, which are all active within the plant. But CBD, or cannabidiol, has got a lot of attention. It's one of the mainstays of treatment for epilepsy, for instance. So pharmacologically, CBD is an anticonvulsant. It antagonises the effect of THC, so it brings down that psychoactive effect of THC, meaning we can use increased doses of THC without having psychoactive side effects in our patients. It's analgesic, and importantly, it's anti-inflammatory. This is one of its major components of action. It's antiemetic, it's anxiolytic, and neuroprotective. Importantly, and I can't stress this enough, CBD has no psychoactivity whatsoever. CBD is an interesting molecule, and it's got a lot of press recently. It actually works. THC binds directly into the cannabis receptors and has its function depending on where it binds. CBD is slightly different. It heals via many different pathways, which I won't go into a lot of detail here about. But rather than bind directly to the receptor, it's more of a neuromodulator in the sense that it binds to the cannabis receptor and changes the way other cannabinoids, including THC and our own endocannabinoids, bind. And this is how it has its major effects. So one of the ways in which CBD works is it inhibits the enzyme FAAH, which is the enzyme that breaks down anandamide. Anandamide is one of our body's main endocannabinoids. So this increases our body's endocannabinoid levels generally, CBD also interacts with the dopamine and serotonergic systems. It's also a GPR55 antagonist. So those receptors are found in the brain, the spleens, adrenal, the gastrointestinal tract, and the bones. So this is another way in which it works. Important to note, and it's slightly out of order, but CBD antagonises the enzyme cytochrome P450 in the liver, which I'm sure you're all aware of. I found clinically in levels above 70 to 100 milligrams per day, CBD does have the effects as stated on the package, in the effect that it slows down the metabolism of the cytochrome P450 enzyme, which has implications in drug metabolism, for instance, warfarin and phenytoin. So any conventional pharmaceutical compounds that are broken down by the cytochrome P450 enzyme, we should take care when prescribing high doses of CBD. Saying that, generally you don't prescribe above 100 milligrams of CBD to most patients, so it's not really relevant in that sense, but it is when you're dealing with epilepsy, which is one of its main treatment pathways. So this brings me to the Entourage Effect. In the cannabis plant, as I mentioned, there is a lot of compounds, THC and CBD being the main ones, but there's also a lot of terpenes, many other cannabinoids and flavonoids in there. Now, from clinical use, and as Dr. Mashulam has elucidated in his studies, these compounds work together. They work together so that their function is more effective when they're working as a team. When you separate the cannabinoids out, we tend to find that they're clinically not as effective. So these are the main phytocannabinoids. We've got THC, we've got CBD, and other minor ones, cannabigerol, cannabichromine, cannabinol, many other cannabinoids. But the two main ones we need to think about initially as clinicians is THC and CBD. Now, terpenes are the aromatic compounds that we find in fruits, flowers, and interestingly, all terpenes on the planet can be found in the cannabis plant in varying ratios. And these terpenes have different effects. So the smell of pine is alpha-pinene, and that's also found in cannabis plants, often in sativa varieties. And that's an anti-inflammatory and a bronchodilator. Linalool out of lavender is a calming sort of terpene. So when we get to a deeper level of cannabinoid medicine, we start to consider these terpenes and how we use them. Strain. Once again, I'm slightly out of order. I am coming back to the endocannabinoid system, but these are concepts which I would like you to know. You'll often hear the term whole plant medicine. That means to take the cannabis plant and extract all the compounds out of it as they are, essentially, concentrating them, but as they are in the ratios they are. And this is how we get our different ratios of medicine. So you may need a higher CBD medicine for epilepsy, for instance, or a more balanced ratio, or a higher THC medicine for pain relief. Now, the best way to get these medicines, and the most effective clinically, is to extract them from the plant. So whole plant medicine is very important. The two major types of cannabis are Sativa and Indica. Now, these aren't strains, but just types. Strains are actual different types of flower. But the two general subgroups are Sativa and Indica. Sativa is generally better for a daytime use. It's more energetic and uplifting, whereas Indica is more muscle relaxant, more calming, more assisting in sleep. So it's useful to time your different types of cannabis at different types of day as well, clinically. So there's many responses physiologically to the cannabis plant, and we see that through the myriad of diseases which are actually relieved by use of this medicine. And how do they work? They work via interaction with the endocannabinoid system. So what is the endocannabinoid system? Each of us, all of us in our bodies, have a physiological system discovered in 1992. It's always been in our bodies. It's called the endocannabinoid system. What it does sits above all of our other systems. It sits above thermoregulation. It sits above appetite and digestion, bone growth and osteogenesis. It sits above endocrine secretion, neural firing, inflammatory response, immune response. Literally all of our systems are maintained in a homeostatic state by the endocannabinoid system, meaning whenever stress is placed upon our body, be it injury, be it increased neuronal firing of epilepsy, in a healthy human, their endocannabinoid system will kick in and try to bring that response back into a normal balanced range for us, keeping us healthy. Sometimes this gets a little bit out of whack, a bit deranged, and then we end up with disease states. So this is the basis of how the endocannabinoid system works. And the interaction of plant cannabinoids with the endocannabinoid system is how healing occurs in our patients. Not the medicine itself doesn't heal, it's our own bodies and our own endocannabinoid system that does. So the main endocannabinoid is anandamide, and it comes from the Sanskrit word meaning bliss. The other main cannabinoid is 2-AG, or 2-arachidonyl glycerol. Now these two molecules bind directly to our cannabis receptors, and the THC molecule from the plant is analogous to these two endocannabinoids, our body's own internal cannabinoids. So it's a homeostatic regulatory system influencing multiple physiological systems. So immune function, cardiovascular function, metabolism, inflammation, sleep and wake cycles, thermoregulation, pain, stress, neural development, reproduction and fertility, emotion and mood. Basically everything our body does, the endocannabinoid system is intimately involved. So we have endocannabinoid receptors, and this is a close-up electron microscope of an actual endocannabinoid receptor. And there's two main types. So I'll get back to that. Endocannabinoids are found throughout our life cycle. They're in us right now, they're in you right now, and they're actually found at extremely high levels in the breast milk at birth. So it says to me there's a lot of importance based on these molecules in the endocannabinoid system. They're found at the stage of embryology. So from birth to death, our endocannabinoid system is intimately involved in our life and well-being. This is Dr. Meshulam, discovered the THC molecule in 1964, and he states that the endocannabinoid system is an essential modulatory and protective system which allows the human body to adapt to various internal and external stimuli. It prevents excessive reactions by other systems in the body. This is just a more complicated way of saying that there from Dr. Meshulam. And how does this work? How can it make things go up and make things go down depending on where it is? That comes back to the way cannabinoids in general act on the neurotransmitters. They're not actually neurotransmitters, rather they're neuromodulators. So we get an impulse that comes down the nerve synapse, and it releases calcium and releases neurotransmitters across the synapse. Now they call this retrograde signaling, because the body decides whether or not that response is too high or too low, and then it will send back, it'll create on demand our body's own endocannabinoids, which will go to the presynaptic receptor and slow down the firing and the release of neurotransmitter of that receptor. So it depends on which receptor it's working. If it's on the adrenergic system, then it'll slow down that response and decrease the stimulation, so it works in a downwards way. Similarly, it can lift up systems as well. So there's two main types of cannabis receptor. Cannabis 1 receptor and Cannabis 2 receptor. So the Cannabis 1 receptor is located mainly in the central nervous system. THC binding to this receptor actually produces the psychoactive effects associated with cannabis. And in fact, it's the most widely expressed G protein receptor in the brain, 10 times more numerous than opiate receptors. So to me, this says this is a very important system that we're talking about. They're also expressed peripherally, but more centrally concentrated in the brain, spine. And they're found in very high concentrations in the cortex, the basal ganglia, the hypothalamus, cerebellum, amygdala, and spinal cord. Very interesting and very important to note. There's no cannabis receptors in the area of the brainstem associated with respiration and heart rate. So at no level of THC use will there be any respiratory or cardiovascular depression. Very safe medication. Cannabis 2 receptors are more peripheral and they're associated more with immune function and inflammation. So they're expressed on the cell membranes of our white blood cells, our T cells, our B cells, and our macrophages. And their expression is inducible, meaning their concentrations can be upregulated in response to stress, so inflammation or tissue cell injury or hypoxia. And importantly, they're expressed also in glial cells, so they have an important neuroprotective aspect here. So once again, they're stimulated by the cannabis 2 receptor, by the THC compound, but the cannabis 2 receptor is the main site of action for CBD or cannabidiol. So this is why cannabidiol is so strongly associated with anti-inflammatory and immune effects of that compound. So this is just a picture of the proteins making up these molecules across our membranes throughout our body. And this is indicating the distribution of radio-labeled cannabinoid receptors. So as you can see, once again, central predominance there. So the cannabinoid receptor responds to various things. It responds to our own endocannabinoid receptors. They respond to external cannabinoids, and they're not all or nothing. There's a lot of shades of grey in the response curve of these molecules, and that's how we get such varied therapeutic effects and physiological effects. So the concentration of the ligand or the thing that's stimulating those receptors is important. The presence of other cannabinoids is also important. So cannabidiol and other cannabinoids, as well as terpenes and flavonoids, once again the entourage effect, are all affecting how those ligands are binding. So all the other compounds in the plant not only assist the THC that we're putting into our bodies as a medicine, but also assist our endocannabinoids having their function. So that's the entourage effect explained from a different point of view there. This is just another slide indicating centrally where the cannabis 1 receptors are concentrated. So in the cerebral cortex for thought, hypothalamus, temperature regulation, water balance and reproduction, amygdala, emotion, emotional response, fear, hippocampus, learning and memory, brainstem, temperature regulation and water balance, cerebellum, motor coordination, spinal cord, pain. So these are the areas which we can use clinically. This is another slide indicating the similar thing there. This is another slide just showing the wide variety of situations and positions in our body where we can find cannabis receptors and obviously use them in our treatment of our patients. Cannabis medicine is amazing in the fact that you can treat multiple systems at the same time with one medication with minimal side effects. So it's not uncommon to have a patient come in, say looking for help with their pain, but they also have concurrent anxiety and depression. And it's very common for a reduction in both pain medications and the anti-anxiety medications as well. So this is a slide just indicating here that there is no possibility of overdose from cannabinoid medicines at all. Respiratory depression is impossible. Though it should be noted that when you're using cannabinoid medicines with other psychoactive medications and CNS depressants especially, that there can be an exaggeration of those effects. So benzodiazepines, alcohol, barbiturates, any of these things, when used in conjunction with THC in particular, you may get an exaggerated effect from the conventional medication, and we may need to reduce that medication accordingly. This is a slide just showing what can trigger these receptors, and we've mentioned them already. So we've got our endocannabinoids, our phytocannabinoids, and synthetic cannabinoid compounds. But these compounds have been found to be not very effective in clinical practice and in fact quite dangerous. The one here I'm mentioning is rimnabant, which has complete antagonism of cannabis 1 receptor, so it blocks that receptor completely. It did have the desired effect of reducing appetite in obese patients. Unfortunately, it made some of them suicidally depressed, and there were some large problems with that trial there. So natural is best when it comes to cannabis medicine. There are other atypical cannabinoid receptors within the endocannabinoid system. So there's various different G protein receptors, vanilloid receptors, as I mentioned earlier, the serotonin and 5-HT receptors associated with dopamine, glycine receptors, and PPARs. So all these atypical receptors add to the effects of cannabis. We look mainly only at the CB1 and CB2 receptors. These are the main points, but there's a lot of other receptors in our body. And I think this variation between receptor, ligand concentration, different inputs and different molecules being bioactive in the plant gives us the amazing subtlety of control in our treatment, but amazing subtlety of control in our bodies. So THC itself upregulates the endocannabinoid system. So small doses, low and acute doses of THC have been shown to upregulate our endocannabinoid system in the sense that they increase our own body's endocannabinoid production. It upregulates CB1 density and CB1 binding affinity, enhances the pain relief provided by our own body's endocannabinoids. So it increases its own therapeutic window. Saying that, THC at high doses will downregulate the endocannabinoid system with receptor synapse involution of receptors, so tolerance. This is only with chronic and high dosing of THC. So THC is the more potent of the two molecules that we're going to be considering tonight. Usually dosing doesn't get above 30 to 50 milligrams per day, and I consider a standard dose 15 milligrams. So THC, when it comes to THC, a little goes a long way. CBD is an endocannabinoid system modulator. It has multiple mechanisms of action on our endocannabinoid system. It doesn't have much binding affinity to the cannabinoid receptor itself. As I said, it binds allosterically, so on the side of the receptor. It increases endocannabinoid signaling by suppressing FAAH, as we mentioned earlier, which is the molecule that degrades anandamide, sorry, not THC, anandamide in our body. So it leaves an increased level of anandamide in our synapses and results in increased cannabinoid receptor activation. CBD is an antagonist of THC on the CB1 receptor, means it decreases the psychoactive effect of THC. So, especially in cannabis-naive patients, it's often a good idea to start with a CBD high medication before introducing THC, and definitely to include CBD in the balanced mix of the medication you provide to help reduce that psychoactive effect. And that allows us to increase the amount of THC which we can actually use before the patient is having bad side effects from overstimulation. CBD stimulates the release of 2-AG, another endocannabinoid, and it's an agonist of the TRPV1 receptor, which is associated with pain. Increases serotonin binding via activity on the 5-HT1A receptor, and is a GPR55 antagonist. So they're found throughout the brain and cerebellum, involved in blood pressure, bone density. So overactivity of that GPR55 will result in osteoporosis, and CBD will actually slow down the resorption, so increase bone strength effectively. And a lot of our common drugs that we use all the time as GPs act via the endocannabinoid system. So for instance, NSAIDs, ibuprofen and ketorolac have a cannabinoid mechanism of action. They block the hydrolysis of anandamide by FAAH again. And they're COX-2 inhibitors, increasing 2-arachidonyl glycerol release and increasing cannabinoid 1 signaling. Paracetamol, once again, acts via the ECS by blocking the breakdown again of anandamide in our bodies. Steroids or glucocorticoids acutely glucocorticoids will upregulate the endocannabinoid system and increase cannabinoid receptor expression. So that's why we get decreased inflammation when decreased inflammation when using glucocorticoids acutely. Chronic use, however, will down-regulate the endocannabinoid system, and this is also consistent and relevant in patients which are under chronic stress all the time. And once again, benzodiazepines, the anxiolytic effect of benzodiazepines are associated with cannabis 1 receptor activation. It's talking about the bone there. So a quick summary of the endocannabinoid system. It's widely distributed throughout our entire body, and the primary function of the endocannabinoid system is homeostasis. This is the system which our plant phytocannabinoids, cannabis medicine, interacts with to create healing modalities in our body. There's receptors found in all of the body systems, and the complexity and subtlety of control allows for a large variation of response and fine-tuning of clinical response as well as our body's response. This is by a partial, not complete, agonism and antagonism. So manipulation or use of this endocannabinoid system has massive therapeutic potential, and I've seen this clinically in my practice as well. How do we keep our endocannabinoid system? Why is that important? We need a healthy endocannabinoid system so that our plant medicines can work properly. So we need to consume more omega-3 fats. This is important. We need to avoid inflammation and inflammatory foods. So anything which causes inflammation or stress in our body triggers our endocannabinoid system to reduce that stress, reduce that inflammatory response. So effectively, by cutting out things that we put into our body which are inflammatory, we have more endocannabinoid system reserve with which to become healthy. Probiotics have been shown to increase endocannabinoid receptors and endocannabinoids within the gastrointestinal tract. Light exercise, regular exercise, is also very good for upregulating the endocannabinoid system. On the other hand, forced and excessive exercise has been shown to downregulate this system. Meditation is another way of reducing stress and increasing our endocannabinoid system's tone. Physical therapy such as massage and osteopathy have also been shown to increase endocannabinoid levels in our bodies. And of course, phytocannabinoid supplementation or medicinal cannabis. We can put these substances into our body and tone up our endocannabinoid system and have these effects this way. So generally we need to decrease stress and decrease cortisol levels. There's other dietary supportive measures which you can do as well. More of them a little bit more outside of the scope of most patients' diet, but they can be included as well and will help tone the endocannabinoid system. Basically, we need to decrease the stress in our bodies, and we get decreased cortisol production, and they have decreased demand on the ECS, the endocannabinoid system, and then we have more ability for our body to respond to stresses when we need it. So this brings me to near the end of my talk, and Dr. Russo is a doctor from a cannabinoid clinician and doctor from America. He's very prominent in the medicinal cannabis area, and he's come up with a term called clinical endocannabinoid deficiency syndrome. Now he's hypothesized that a dysfunctional endocannabinoid system could actually be the reason behind a lot of the inflammatory conditions that are so common in our practices. So anorexia, motion sickness, fibromyalgia, Huntington's disease, IBS, UC, ulcerative colitis and Crohn's disease, menstrual problems, migraines, MS, Parkinson's, PTSD, schizophrenia, seizure disorders and mood disorders and depression. So as you see, these all have an inflammatory basis to these diseases. So it's important that we look at how to support this endocannabinoid system, and one of the main ways to do that is by supplying phytocannabinoids or plant cannabinoids. So this is a statement. Cannabinoid medicine involves patient-specific, personalised treatment protocols. Due to the individual genetic variability of expression of the endocannabinoid system, and thus response to treatment with exogenous cannabinoids, every patient's treatment plan will need to be slightly different. Each patient would require titration of cannabis medicines to facilitate effective treatment of their unique condition. Cannabinoid medicine requires a physician to be both a scientist and a healer. I believe there is an art to the utilisation of these cannabinoids in the effective treatment of disease and for the relief of associated negative symptoms of the disease state. It's a very complicated way of saying this is a very personalised medicine, and we need to look at each and every one of our patients personally. We can't just say, okay, this is a pain patient, we'll give them this many milligrams, off you go. There's more to it, and we need to look into the reasons why they're in pain, how they respond to the plant medicines, monitor those plant medicines, and also listen to them for feedback as to how the treatment is going on. So each patient's endocannabinoid system is unique, so each patient's treatment protocol must be unique. And I can't stress enough the importance of whole plant medicine. There's multiple physiologically active compounds in cannabis, not just the THC and not just the CBD. So, extracted cannabinoids have been shown to have decreased clinical efficacy. Whole plant medicine is definitely the best. So we need to select strains with cannabinoid ratios that suit our clinical purpose, and I'm sure Dr. Jansen will talk to you more about that. We can also combine two or more different plants to get the ratio that we're looking for. So the ratio we're talking about here is cannabidiol versus THC. So in epilepsy and seizure conditions, we'll use a high CBD ratio, often 20:1 ratio, CBD 20, THC 1 part. For pain, a balanced or a high THC medication is the way to go. So 1:1 THC to CBD, and in some cases, often due to cost restraints in Australia, I must admit, I will increase the THC separately from the CBD with a CBD baseline. And also, we need to choose plants that suit the time of day for that patient, as mentioned earlier. So that covers my introduction to the endocannabinoid system. I know that's probably created more questions than answers, but hopefully it's given you a basis of understanding to take you through to the next part of the talk tonight. Thank you very much.